This is the second lecture on catecholamine-induced polymorphic VT, and the focus of this lecture will be on treatment. My name is Arthur Wilde. I'm a cardiologist in Amsterdam University Medical Center, location AMC, and I'm the coordinator of the ERN Guard Heart. So treatment is the topic of this talk. A couple of introductory slides. The first one is catecholamine-induced polymorphic VT, VF, is an autosomal recessive, autosomal dominant disease, but can be autosomal recessive as well. It is genetic heterogeneous, and at least 6 genes have been shown to be related to CPVT. Complaints exclusively occur during exercise and emotion. It can start at a young age, and the baseline EKG is usually normal. The genes involved is the ryanodine receptor type 2, that is the most frequently involved gene. Calsequestrin Q2 is involved in a homozygous form of CPVT. KCNJ2 is involved in CPVT3, and a couple of minor genes are involved in the other subtypes. The pathophysiological mechanism relates to diastolic calcium overload in the cytosol, and in the case of the ryanodine receptor is caused by a leaky ryanodine receptor leaking calcium during diastole in the cytosol. This is an example, a male 38 years old. He has no complaints, and the EKG is prior to exercise, and it was made because his brother died at age 32 during a soccer match. So his baseline EKG, as you can see here, is completely normal, but with some minor exercise, only 3 minutes here, polymorphic ventricular ectopy develops. You're looking at only the precordial leads, but you can still appreciate this is polymorphic ventricular ectopy with a doublet here and even a triplet here, which is polymorphic in nature. Diagnosis can also be made with Holter monitoring. This is 12-hour heart rate monitoring in a patient whose heart rate is stable during the day, and between 6 and 7 in the evening there is some exercise, and right at that time there is ventricular ectopy, and even there is some ventricular tachycardia exactly at this time. This is suggestive for CPVT. The treatment of CPVT is about lifestyle advices. Competitive sport should probably be discouraged. Try to avoid strong emotions and exercise. And when it comes to medication, beta-adrenoceptor blockade is the first medication of choice. This is some meta-analysis of early series where the effect of beta blocker was studied. And as you can see, beta blocker response is not 100%. In this series, by priori, it's only 63%. And here, this is the largest series with 81 patients. It is 77%. We did an analysis of the event rate on beta blocker of all the published studies before 2012. The time since diagnosis is on the x-axis, and the arrhythmic event rate, counting all arrhythmic events, is on the y-axis. The size of the circle is the size of the study. This is the Hayashi paper from 2009. And as you can see, there is almost a 30% recurrent event rate on beta blocker in CPVT patients. Of more concern is the near fatal arrhythmic event rate, which is also present in more than 10% after 8 years. So beta blocker alone may not be sufficient. Flecainide has been proposed to be an effective additional treatment. And further additional treatment is left sympathectomy and ultimately ICD implant. So first, some comments. Flecainide. Flecainide is already in the guidelines. This is a paper from 2013, the guideline paper from 2013, where Flecainide is considered a useful addition to beta blockers in patients with a diagnosis of CPVT who experience recurrent syncope or still have arrhythmias on their exercise test while on beta blocker. The effect of Flecainide is based on this paper from Björn Knollmann, where he showed in experimental models a positive effect of Flecainide. And the first clinical paper on this was from our center, together with many investigators from around the world with seriously affected patients. And Flecainide was given here to 29 patients who were not completely protected by beta blocker. These patients were on a stable doses beta blocker during the time of the study. Follow-up was with a median of 20 months, and only 1 out of these 29 patients received an ICD shock, and that patient was inadherent to Flecainide. This is the overall study result. The arrhythmia burden is subdivided into different groups: non-sustained VT at the top, couplets during exercise tests by Gemini or frequent ventricular premature beats, and no or an isolated ventricular beat. As you can see, the majority of patients is in the higher categories, and upon Flecainide therapy with a stable dose after 21 days repeat exercise test, the vast majority is in the lower category. And the one patient that is still here in the non-sustained VT has a significant reduction of the duration of the VT. The effect is sustainable over 5 years period. This is from the same series, unpublished, but as you can see, if you follow these patients for 5 years, then you can still see that they are almost all free of serious arrhythmias during an exercise test 5 years later. We are now working in the International CPVT Registry. Participating countries around the world are here in red, and the number of patients from different centers around the world are indicated here. In total, there are 1,166 cases as of November 2018. So the 1,160 cases are here, equal distribution between male and female. 1/3 is proband, 2/3 is family members. And the presentation of these individuals is that almost half of them have no symptoms. Some have palpitations. 1/3 has a syncopal event. 172 patients presented with an aborted cardiac arrest, and some presented with sudden cardiac death. Within this registry, we selected the patients with Flecainide, almost 150. The patient characteristics are indicated here. 90% has a ryanodine receptor. Median age of diagnosis is 16 years of age. Almost all were symptomatic before diagnosis, and 20% were symptomatic before the start of Flecainide. This is the overall result in the same format as I've shown you before. The arrhythmia burden prior to start of Flecainide is here, and the arrhythmia burden in the most recent exercise test on Flecainide is here. And there's also an important shift here from more severe arrhythmias to less severe arrhythmias on Flecainide. There is one attempt from Prince Catecholaminergic from Nashville, Vanderbilt University Medical Center, where they tried a randomized clinical trial to study the effect of Flecainide in these patients. This was a multi-center prospective trial. They aimed to include 60 patients, and all patients needed to have an ICD, but it turned out that after 4 years there were only 14 patients enrolled. And then they decided to change the outcome of the paper to the effect during an exercise test, and they were able to show a very strong arrhythmic effect in 13 out of these 14 patients. 2 patients received 3 shocks. 2 were on Flecainide. Serum levels, unfortunately, are not available, and none of these patients had left sympathectomy. So also this attempt for randomized trial seems to show that Flecainide is highly effective in the treatment of CPVT. The third option is stellate ablation of the gangliostellatum at the left side. The rationale of that is that it reduces norepinephrine release in the heart. It has been shown that it increases the fibrillation threshold and it decreases repolarization inhomogeneity. There is an increase in afferent vagal nerve activity, and there is no alpha adrenergic stimulation anymore. And altogether, this brings a strong antiarrhythmic efficacy. The left stellate ganglion schematic scheme is here. This is the stellate ganglion. This is T2, T3, T4, and the sympathetic innervations from these stellate ganglia all go to the left ventricle. The cut should be somewhere here in the middle of the left stellate ganglion. In more detail, the same picture in more detail is here. You can see that the sympathetic innervation in this schematic drawing is for the left ventricle. You have to be careful with the cut in the stellate ganglion itself, because there is the recurrent nerve which goes back all the way to the brain, and if you cut too high and you damage this part, a Horner syndrome will be the result. The first evidence that this is a useful addition in these patients comes from our paper in 2008 in the New England Journal of Medicine on only 3 patients. These patients were all ryanodine receptor mutation carriers, and they were all on maximum dose of beta blocker. And the clinical characteristics are here. You can see they are severely affected, out of hospital cardiac arrest in these patients, multiple syncope here, and ICD with multiple shocks in the 3rd patient. Left sympathectomy was performed at age 18, age 17, and age 16, and follow-up was between 20 and 2 years. This is an example of one of the patients. This is the exercise test pre-left selectomy, and you can see the occurrence of polymorphic ventricular arrhythmias during exercise. This is in the same patient 2 months after left sympathectomy. With even a faster heart rate, there are no arrhythmias anymore left. The way to present that is this arrhythmia burden. What you see here is the test before left selectomy. This is the duration of the exercise test between 0 and 5-6 minutes. The end of the exercise test, completely uncoupling of the EKGs here at 9 minutes, and the end of the exercise test is here. Heart rate goes up from 60 to 120, 130, which means that the patient is effectively using beta blocker and Flecainide probably, and the burden of ectopy is high, as you can clearly see here. Ventricular exercystolis per minute. There's a cutoff here, so it's more than 50 per minute after 3 minutes during exercise. Ectopy completely ceases and very fast when the exercise test is stopped. So in this patient, this was a test 2 years before the left sympathectomy. This is the 1.5 year before, and this is half a year before, and the ectopy burden is significant. And only 2 days after the left sympathectomy, you can see that there is hardly any ectopy left. There seemed to be some minor recurrence after 10, 12 days and after half a year. And all the 3 patients had a very similar response. A larger series of this was this worldwide collection by Gaetano de Ferrari. He had 54 patients where left sympathectomy was done as a secondary prevention, so worldwide. Major cardiac events are here pre left sympathetic denervation, and post are here, and you can see there is a very important shift towards a very low number or none at all of major cardiac events. What about ICD treatment? That is a topic in itself that I would like to address in a separate talk, and that will follow soon. So this is the end of the second talk. Thank you very much for your attention.